According to the Office of Fair Trading in 2007, countries with reference pharmaceutical prices to the UK included Belgium, Canada, Finland, France, Hungary, etc., etc., etc. You can all see them in this figure. So in 2007, these markets accounted for around 25% of world pharmaceutical sales, while the UK pharmaceutical market itself accounts for just over 3% of global sales only. I find that really remarkable. So we reference our prices to the UK, but the UK only accounts for just over 3% of global sales. So pharmaceutical prices in the UK will likely impact prices in countries that reference their prices to the UK. According to an agreement, the accord, do I say that right? Between the Healthcare Products Pricing Committee and the Association of the Pharmaceutical Industry, an initial listed price for pharmaceuticals in France with an ASMR rating of 1, 2, or 3 that is consistent with the prices in place in the main EU member states. This means that the initial listed price should not be lower than the lowest price observed in Germany, Italy, Spain, and the United Kingdom. The initial list price for these products, for these drugs, is fixed for a period of at least 5 years. After this period, the list price may be renegotiated, and external reference pricing is not, per definition, the main tool used during these negotiations. Again, I wanted to give you a little bit of a lecture of how reference pricing system works, because France has both external reference pricing and internal reference pricing. So not only are you looking at, the therapeutic equivalence, whatever that definition is, but you're also saying, once we've established which class this drug belongs to, you're not objectively looking at the innovativeness of this drug that you cluster, but you're simply looking at other countries and say, well, this is what the other countries do, forgetting about the context of their healthcare system, their culture, their background. So I find it very odd, and France is not the only country that does this, so sorry. So I wanted to briefly touch upon how France defines value. So the pricing strategies differ between ambulatory care and hospital settings. HAS assesses all new drugs for added therapeutical value and categorizes them in one of the 5 groups. And I think some of you already touched upon this. So I'm not going to get into this, but so external institutions basically define whether it's improvement or no improvement. And I keep questioning always when I hear this. We have a similar institution in the Netherlands. If I talk to Pierre about, the U value going from an S5 to an S7, we might, have a very different opinion about this. So even if you ask clinicians or people who seem to really understand the therapeutic innovation of a new product, you might have a very strong difference of opinion about what it could potentially add to public health. And as I said, the perspective also really matters. Are we looking at this question from a societal perspective? Are we looking at this question from an individual patient perspective or from a political perspective? And it's really important to keep in mind, with whose eyes we're really doing these assessments of value of drugs. So, so we're looking, some objective measures that you see across countries are the effectiveness and possible side effects. So that's, to some extent objective. The position in the therapeutic spectrum relative to other available treatments. This is one that I find a little hard to understand as well, because, we always hear this story about, how incremental innovation in name a product that everybody uses. Lipitor, for example, at Pfizer was long debated for 15 years because it would not add any value to existing drugs. But the question is, does it add any value to an individual patient? And if so, the initial reference pricing definition that I gave you at the start of my presentation, you would assume that if I were an individual patient, I would get information about the potential innovation that this drug might bring me, but there is no such information in our current healthcare systems. So I find it very difficult sometimes to assess what the therapeutic spectrum relative to other available treatments is, because in the area of cancer drugs, for example, it's relatively easy to come up with something that is relatively new or spectacular relative to other available treatments. So that's another point to keep in mind. So moving to the next slide. External reference pricing is basically the main tool that France uses for most of their patented drugs in the ambulatory settings. In addition to set the reimbursement tariff of most innovative hospital drugs that are reimbursed directly by statutory health insurance here, external reference pricing is used as well. So the use of external reference pricing basically means that prices of new patented drugs are determined before the drug actually enters the market. External reference pricing can also be used as an argument to decrease the drug price during later stage negotiations. So prices are derived from the sources described in that process at all times. I want to quickly move to the next slide. So you may wonder what the impact is of a reference pricing system on price competition. I've actually dug into the academic literature, and that literature suggests that the introduction of a reference pricing system reduces prices of all medicines that are included in the system. But I didn't need to dig into the academic literature to come up with that conclusion, obviously, because it's a very old-fashioned mechanism. If we force prices to go down, of course overall spending will go down. So price reductions tend to be larger for originator medicines than for generic medicines. That's also logical. If something is more expensive and you want things to get cheaper, then you drive the innovative products further down. Also, greater price reductions have been witnessed in markets where generic medicine competition already occurred prior to the introduction of the reference pricing system. So the European experience with respect to price reductions below the reference price is actually mixed. Such price competition has actually occurred in some countries, but there are in particular regions, particularly Eastern Europe like Lithuania, but mostly not the rest of Europe. So Spain, Western Europe, Slovenia. I found a study on Portugal as well. So conversely, some medicines that were originally priced below the reference price actually increased their prices to the level of the reference price following the implementation of the reference pricing system. So in addition to setting reference pricing as a function of the prices of existing medicines, some countries have actually established a fixed minimum price difference between generic and originator medicines. I noted Finland does that, Portugal, Spain, but also the Netherlands actually. The number of generic medicine competitors within a reference pricing system appears to be associated with the extent of competition, although this impact occurs mainly through discounting to the distribution chain rather than through price competition. So larger discounts have been observed when there are more generic medicine competitors. Finally, as compared with other mechanisms to regulate prices such as price caps, a system where the regulator sets a maximum price that can be charged for a medicine, a study in Norway actually reports that a reference pricing system stimulates generic competition to a greater extent and leads to lower prices than price cap regulation. In Germany, medicine prices dropped from 10 to 26% in the first years following the introduction of reference pricing in '89. And I can give you many, many more examples, but again, I think that it speaks for itself that if you drive prices down, that there will be generic competition. The question is, do we really want to drag the innovative industry into that circle of generic competition? So in general, the implementation of a reference pricing system has been accompanied by an increase in the use of medicines priced at or below the reference price. However, a review that I also read indicated that a reference pricing system does not aid generic medicines. Medicines uses, so if prices of originator medicines fall to the level of the reference price, the originator company launches new dosages or new formulations, or physicians switch to patented medicines with a similar therapeutic indication that do not fall on the reference pricing system. To give you an example, in Germany, therapeutic reference pricing applies to the group of statins since 2005. And as a manufacturer of atorvastatin, claimed that it was superior to other statins, and as I said before, I've heard that discussion for more than 10 years now. In terms of side effects and drug interaction profile, the manufacturer actually kept the price of the atorvastatin above the reference price. And it was really interesting to see what happened in Germany. As a result, the market share of that newer statin actually declined from 33% prior to the reference pricing system to 4.8% in 2006. And again, whatever you may think of the issue, you may question, is that really what we want to be doing? So this volume shifted mainly towards simvastatin, to which no additional patient co-payment was applicable, as its price was below the reference price. And I wanted to add one more fact, which is if you introduce a system like this, and I know the country that is closest to my experience is the Netherlands, again, the whole basic reasoning of reference pricing, barred from other markets, is that consumers have information about the value added of products that are actually more expensive. And in the Netherlands, the patient actually goes to the pharmacy, and the government came up with regulation that a pharmacy actually has the right to generic substitution. So even if a doctor says you need Lipitor or name it, any branded name drugs, because in your specific situation, I think that this is value added, an MD draws this conclusion, not me, an MD does that. Patient goes to the pharmacy. Pharmacy says, I'm going to give you another statin because it's therapeutically equivalent. I find that odd, but so okay. I just wanted to also just touch upon the impact on the long run expenditure. So I find it really interesting that literature review has actually indicated that reference pricing do generate savings in the short run, but that savings are actually probably limited to the one-off impact of the introduction of reference pricing systems, and that savings may actually not be substantial in the long run. So this figure actually shows you how the introduction of a reference pricing system may impact long-run pharmaceutical expenditure, and the limited scope for savings is to be expected for at least two reasons. First, the coverage of reference pricing systems tends to be limited to off-patent medicines. Patented medicines are included in the reference pricing system by therapeutic class in some countries only. This is Europe-wide. Second, although a reference pricing system may reduce medicine prices, it may affect the substitution of new, more expensive medicines for older, less expensive medicines. It does not affect other drivers of increasing pharmaceutical expenditure, such as medicines used by aging populations, the introduction of expensive biotechnology medicines, orphan medicines, also touched upon today, and its transformation from acute to chronic diseases. And I think particularly the latter, in the context of public health, is one that we should really worry about. So, potential concern of therapeutic reference pricing is that switches in medicines used in response to the reference pricing system may adversely affect patient health outcomes and thereby increase the use and costs of other healthcare services. There are actually a few studies that explore the impact of reference pricing systems on health, and they do suffer from some methodological limitations, but they also find that there's no association between reference pricing systems and health outcomes. But these studies actually all focus on the short run. So again, there's no cost study in the long run, basically taking into consideration inhibitors, other therapeutic treatments that replace, that are needed to basically treat patients in the long run. So I'm going to leave it here, but I'm looking forward to discussion.
C'est un panorama très vaste et très détaillé qui nous montre bien les différents choix européens. Alors on a entendu la place que tenait le Royaume-Uni particulière dans ce système. Daniel MAHONEY va nous en parler, des avantages et inconvénients du système britannique de régulation des dépenses pour les soins les plus innovants. Vous êtes directeur de recherche économique au Centre for Policy Studies à Londres. Voilà, nous donnons la parole pour un zoom sur la situation britannique. Merci.
Okay, thank you very much for that. This is going to be a far broader and more general sort of look at things. So it was very fascinating speech you just heard. So I'll briefly discuss the UK's regulatory system for the pharmaceutical industry, where the UK performs particularly well, and also where we perform very badly. I'll try and strike some comparison between the UK and continental Europe. So the UK's pharmaceutical regulations broadly a tripartite system. So you have the MHRA, which works alongside the European Medicines Agency, which is responsible for safety. Then you have the organisation LEASE, which is responsible for cost control, evaluating cost-benefit analysis, and then also determining whether drugs are allowed to be released into the National Health Service, which is obviously a single-payer system. And then you have the Pharmaceutical Pricing Regulation